So the next I'm going to talk about is 1775. And this was an abstract about using circulating DNA to detect minimal residual disease after surgery in resectable lung cancer. This is such an incredibly important topic right now. Circulating DNA its use is widespread in stage 4, but it's not routinely used in earlier stage disease. But arguably, there's never been a better time to roll that out and to start looking at it in early stage disease, particularly as targeted adjuvant therapies come to the forefront or targeted neoadjuvant trials. Our ability to know which patients are most at risk, which patients need systemic therapy, I think will be critical. The authors looked at specimens from 49 lung cancer patients, and they looked at the mutations in the tumors that were resected. And then they compared those tumors to a blood-based ctDNA profiling from postoperative plasma taken from the same patients. So only if patients had the same mutation in their blood and the plasma postoperatively that they had in their resected tumor did they call them positive. And they looked at a fairly wide range of stages. It was roughly equal between stage 1, stage 2, and stage 3. Obviously, a lot of work has been done on this in the stage 4 space, but much less in the earlier stage space. But remarkably, the authors found that 84% of patients had not just mutations, but actionable mutations that were found in their tissue. If they then looked in the plasma, they found that postoperatively, the positivity rate of circulating DNA was 26.5% in patients. So 1 out of 4 patients is going to have still persistent circulating tumor DNA in their blood, perhaps suggested that those patients are at increased risk for recurrence. And the percent went up from stage 1 to stage 2 to stage 3, where it was 33%. This is an incredibly important finding, and this is really where the science is going. There's obviously been a lot of discussion about adjuvant EGFR and TKI therapy, which patients it should be used in, is it cost effective, is DFS important or overall survival. We increasingly need to move to the idea of targeting that therapy to the right patients. And the chemotherapy, the adjuvant chemotherapy story is a great example. We know that we get anywhere from the 5 to 15% benefit in 5-year survival with adjuvant chemotherapy. But if you turn that the other way, that means that we're only helping about 1 in maybe 8 patients with adjuvant chemotherapy. If we can better determine which patients that we can help that need systemic therapy, be that chemotherapy or be that targeted therapy or be that immunotherapy, then undoubtedly we'll do better and we'll use these drugs in a more cost-effective manner. The world is moving this way. There's a handful of trials that are coming out that are looking at this as a marker in patients with early stage disease. And I expect that we'll continue to see it used in that setting and that we'll see more data forthcoming in the next several years.